It looks like there were some configuration problems that have been fixed. What we are going to do is I will bounce from class to class unless there is no internet, and the classroom that I'm not in is expected to Zoom. I talked to them about this yesterday. Just because you're on Zoom does not mean that you are not going to be in the classroom. They still want you guys to be in the classroom when you're on Zoom, okay? So what this will do for me and make me feel better is that I will see everybody and I will just alternate days on where I'm at. So the day that I'm in the sophomore class, that means the juniors, you will get on Zoom. The day that I'm in the junior classroom, that means sophomores, you will get on Zoom. Y'all can hook it up here if that's how you choose to do it. But if I am the last class, again, to reiterate, you will still stay in the classroom. They are likely going to walk around to check that y'all are in the classroom, okay? So even if you are on Zoom, please be in the classroom, okay? Is everybody tracking over here in this classroom in front of my face? Yes. Are y'all tracking over there? Yes. Okay, so after today, that's what we will do. Unless there's something wrong, then we will fall onto using this or vice versa, okay? If I'm over here, there really is no need for the Zoom, really, because y'all can see over there, but I know some people prefer it because they can lock in and hear with me in their ears. Up to you. Yes. Question, no question? Thought there was a question. Any questions over there? Okay. All right, so let's finish warts. Then we're going to talk about steroids, and then we're going to talk about pregnancy and lactation. It was also brought to my attention that there was an error on the schedule where it says that the juniors have class on Friday for Pharm. We don't have class for Friday on Pharm. So if y'all see that on your schedule, just go ahead and fix it. It was some type of error. I don't know where that came from, okay? I'm going to try to finish today, and then I will let them know that we're finishing class early so that y'all can change the schedule, but I will let you know at the end of class if we don't need the class for tomorrow, all right? So, continuing with our derm lecture and looking at warts. This is just some information about the different types of warts that are hanging out. I'm not going to ask you to diagnose anything, so this is an FYI slide for just information for you to kind of have a background because you haven't had derm yet. And then the different types of prevention and treatment. When we talk about prevention is prophylaxis. I'm giving it to you before something happens, whereas I'm looking at treatment, that means that I have some type of wart and that's what you're trying to treat. So that's where our medications come on board. So when we look at our prevention or prophylaxis, we have vaccinations that are available. So you have your Cervarix and your Gardasil. Your Gardasil is the one that you hear more about and they have more commercials about. So essentially we're trying to prevent genital warts that could be caused by HPV and cervical cancer. The age in which they give this continues to drop. I'm not going to test you on that, but just understand that the same way that we make like a flu vaccine or any of our other vaccines, we're trying to cover as many strains as we can and therefore, again, hopefully prevent that person from contracting any type of cervical cancer or the genital warts that are caused by HPV. We do have some agents that we have where the wart presents on their skin and we give them a medication to try to destroy that wart. So where you see physical destruction of the affected tissue. The big thing here is trying to get that medication on the affected tissue and not healthy tissue, right? So your affected tissue is going to be that wart, which is usually raised, but it's going to be on that wart and not the healthy skin. If you do accidentally get it on the healthy skin, when we talk about some of these medications, you will see where it starts to kill or damage the healthy skin. So looking at our keratolytic agents that we have, which are the most commonly used agents, some of which are over the counter, you have your salicylic acid, your podalophylox, your podalophyllum, imiquimod, and your catechinins. When we look at these, again, a patient can try to treat themselves prior to coming in to see you. There are some times where they might have been trying to treat themselves for a long period of time with one of these destruction agents and it didn't work, and you have to refer them to derm, or sometimes you guys can try to remove them as well with the cryotherapy, laser, or surgery. So this just varies depending on that patient, right, and what they have tried that either successfully worked or did not successfully work for them. When I give you these names, let me get my mouse, sorry. When I give you these names, again, the things that are in bold are those generic names that you're responsible for. The brand names, like always, I will have those on the in parentheses on the exam. Not going to ask you about cryo, laser, or surgery because that's not a medication, which means that's not my wheelhouse, right? So when we look at your imiquimod cream, this one is going to be a topical immunomodulator, and it's going to try to induce that cytokine induction. When we talk about these meds, this one is very good because in this box here, there are 24 packets that they can use, and these are single-use packets because if someone takes it and they're putting it on a wart and they try to save it for later, now it's had contact with that wart, right? And now they're saving something. And if there's no preservatives and medications that we're using repeatedly, now bacteria and all of the things get to continue to grow, and now I'm making my condition worse, right? I'm just putting it right back where I don't want it. So single-use packets that they have, you see there are several different types of warts that you can treat, carcinomas as well. So cutaneous, genital, and perianal warts, external only. This is very important because some people will have warts that are internal, and that requires usually procedures to be done, not taking the medication and internally inserting the medication. So that is a big thing that you need to make sure that the patient knows. If they think that it is an internal wart or genital wart that they have, they should not be taking this medication. Imiquimod should not be inserted, okay, anywhere. It's only external. Looking at your pregnancy, we usually avoid it. And then your adverse effects, just very local reactions, again, because it's topical, it's something that they're putting on their skin. Itching, redness, not a horrible medication to have, and then that superficial erosion. So you see these side effects look a little bit different than a lot of the derm meds that we talked about yesterday. Looking at your pedalophilox and your pedalophyllum resin, again, you're looking at trying to essentially kill those cells that have built up and formed that wart. So I want to destroy it. Again, external only. Don't need you to remember the dosing of how it's applied. I don't need you to remember that. But my adverse effects is very important here. So with this one, you can see that if I accidentally put it on any healthy skin, that I can have necrosis or death of that healthy skin as well, which is not what we want. So a lot of the times when I talk to patients, I tell them to start on the inside and then get as close to the outside of that wart as possible. So depending on how big it is, right? So start in the middle and then kind of work your way out. If it's like a ringworm or something like that on somebody's skin, I tell them to go the opposite way. I tell them to go on the outside and then work their way in so that they don't spread it out. But this, I do it the opposite way because we don't want anything on the good skin. Contraindicated in pregnancy because we think that it might be cytotoxic to the fetus. When we look at our last option that we have, again, still external, right? So your cyanocatechins. With this one, partially purified, okay, comes from green tea components, from green tea leaves. We don't use this one as much. It is a little bit more expensive, and this one sometimes is on the formulary and not on the formulary. So like we were talking about yesterday with a lot of your derm meds, if you're going to prescribe one, go to your TRICARE formulary lookup tool. You can Google that. You type in, it's going to ask you the patient's gender, their age. You put that information in. Sometimes I just like, okay, it's close enough. And then you put in the name of the med, and when you press search, it will tell you, yes, this is covered, or no, it's not covered. It will tell you if you need to complete that prior authorization, and therefore you can talk to your patient and say, hey, I had to do a prior authorization. This has to go to TRICARE first. It may not be ready for you today, right? So they can't just go to the pharmacy and pick it up because we're going to have to wait on that prior authorization. Looking at what we are wanting to happen, right? Upregulation at apoptosis. And therefore, I can try to stop that inflammatory response. So therefore, the down regulation of the pro-inflammatory response, which is your wart that you have. Looking at this one, they are treating themselves for a very long time. And the way that I kind of remember that they need the 16-week treatment, warts are hard to get rid of, one. But two, this one has those green tea leaf components, right? So if something is more natural or holistic, most of the time it's going to take longer for you to treat someone with those types of medications. Avoiding again during pregnancy, and then when you look at the effectiveness of this, right? The medication, 55 versus 35% when comparing it to placebo, not a huge difference. Okay, so this is kind of telling you, I gave this medication and 55% of people saw resolution, but if I gave them nothing at all, 35% of them had resolution. And the price of this medication for a 20% difference is not that worth it. Okay, so there's other options that we have. Your Podalafil, your Amikimud, that would be better than you using your Verigen. Okay, and then boom, there's your cost, right? That's expensive. Now, the benefit of that, this tube could last them for a little while because it's not like extensive, right? They're not putting it over several areas of their body, they're just putting it on the wart. But if I'm looking at something that's over $200, it's a lot of money, okay? And 16 weeks. Here are your memory joggers, okay? So again, just going through this, this is not something that is all inclusive for your exam. This is giving you those wave tops. Make sure you go through the slide deck first and then go here to try to say, okay, can I answer these things that are here? All right? Our next one that we're going to look at, let's see how much this is. Let's pull up your medications in pregnancy, please. Are y'all okay? Everybody's quiet today. We're not okay? How can I help? I don't know if I'm going to do a review. This vibe is not review vibing right now. Let's see how our vibe goes, and maybe we can do a review. Also, I'm waiting. Did y'all figure out the exam stuff? Okay. Let me see. Because I'm also working on this DHA pharmacy course too, so I'll see. I might be able to do something. We'll talk about it. Okay, everybody up over there with the medications and pregnancy lecture? Yes? Okay. All right. So this is a very short lecture because a lot of these things we've already talked about. Is just kind of going over some of the things that we've seen already. Your ELOs are going to be the same things. Now, what I will tell you studying for this for the exam, make sure that you're looking at this in a way of knowing what medications you're using when someone is pregnant or lactating, meaning they're breastfeeding, for these disease states, because that's the way that these questions are going to be directed a little bit more. There are very few mechanisms of action in here that we're going to talk about, and then we're going to also look at medications that are teratogenic to someone who is pregnant, which you've been hearing as we've been talking about some of our meds, but this is going to talk about them again. These are all of the meds that you're going to see throughout this lecture, and now we're looking at the changes that happen. So this is starting exam material here, okay? So when you're looking at drug exposure, a lot of our drugs that are taken during pregnancy can potentially cross the placenta and expose that fetus, right, or that embryo to a certain amount of medication that woman was taking. And therefore, that can lead to teratogenic effects or even pharmacologic effects in that fetus, right? Because if I took something, it's likely that it passed into my stomach, right where my baby is, into my uterus. And therefore, I may be affecting my child negatively, not all the time. A lot of our drugs that we talk about are not actually teratogenic, but we may not use them in pregnancy because they could potentially cause harm, but that doesn't necessarily equate to being teratogenic. So when you look at something that's called a teratogen or something that's teratogenic, essentially you're saying that it could cause a birth defect after someone has had exposure to that medication. You can have different health conditions that could cause teratogenicity. You can have different medications. Which one are you trying to turn on? This? Oh, okay. Y'all have to say stuff. I don't know if you want lights or not. Y'all creating a mood. You got lights over here on the wall. I'm just here. So when you look at this, right, depending on the stage of the fetal development is where we are worried about certain meds potentially affecting the fetus, right? So you have different growth defects that can happen. You can have mental effects, mental retardation that can happen, right? So all of these things come into play and can be affected depending on what medication I give to that child or to the parent. We have structural malformations that can happen, so like cleft palate. You have different like heart defects that can occur. There's so many things, different things that can happen with ears. And then some of our examples that we have, you have thalidomide, isotretinoin, BPA or valproic acid, warfarin, ACE inhibitors, we're going to talk about those, alcohol, nicotine, so many things, right? So these are the things that we're trying to say, oh, you're pregnant, oh, you're lactating, let's try not to expose somebody to these medications. And then your physical chemical properties that you have, this is how we can sometimes manipulate dosing instead of just avoiding something. A lot of different things can change based off of just being in a pregnant state. And with that, we can look at absorption, the volume of distribution, metabolism, all of these things start to change because the body is changing. So the way that we expect for a normal body to perform that is not pregnant is not the same exact way that a pregnant body works. So there are different things that sometimes we have to do whenever we're looking at giving a woman a medication if they are pregnant. Timing of exposure, so again, when you gave them something, how long you gave that to them matters, because in the beginning of conception, right, the baby is forming different things and different organs are forming versus at the end of the pregnancy, right? More things are developed, and now what you start to worry about sometimes more is like, oh, are they going to deliver the baby too soon? Are the lungs going to be developed? Certain things like that. Is this medication going to cause a contraction? Those are the things that we start worrying about a little bit towards the end, but in the very beginning, we're worried about those organs that are being developed. Am I giving them a medication that could affect that? Because that's what leads to the teratogenic effects that we see, and sometimes miscarriages that could happen as well. And then the variability of the response. What just happened? Again, this just depends on the mother and on the fetus and genotype wise, like what they have, right? Everybody responds to different things, the same medication in different ways. And that's even if you're not pregnant. All right, this is looking at thalidomide, and what happened was they used to use this in the 50s and 60s to help with nausea in pregnant women, okay? They were giving this, which is something that's very common. And so they would do this with dexamethasone, which is one of our steroids, as well for like myelomas, different things. And what they found was that you would have them not completely develop their arms. And so this was, again, how we figured out that thalidomide was teratogenic, and we do not use thalidomide anymore. And so that is kind of what made us think about pregnancy categories and things like that. Our meds do and can potentially cause harm. When you're looking at this, this is just I don't need you to remember this, okay? But this is just showing you like, hey, initially, right, I'm forming that embryo, what have you, and then over time, right, this starts to look more like a human instead of a little alien. And you see that different things are being made, right? Neural tube defects can happen here. Mental retardation can happen here. Brain, CNS types of effects can happen here. But a lot of the times, you're more sensitive the earlier on you are, right? Even at this stage, there are things that can happen with medications on top of just genetics doing what they do, right? Or random mutations that can happen, okay? So just understand from here that there are several different stages, and depending on when you're giving something, the earlier stage is usually a little bit more sensitive than the later stage, okay? Less sensitive, more sensitive. Here you see that they have those congenital disorders. So like essentially that's just a disorder that is present from when they're born versus like those functional defects that somebody could have. So those are anything that we can just say is something that's affecting like a structure on their body, like their arms or their legs or their lips are being affected, okay? These are our categories. Does this look familiar? Yes, we saw this a little bit. right? So your categories, this was our old way in which we used to classify pregnancy categories. As you see, we still use them. I still talk to y'all about them. You're still going to hear them. We can't let it go, okay? So category A is the best thing that you have. You have no evidence. There's lots of studies. It's safe, right? You want to have an A. When you look at category X, those are things like you're like, nope, I don't want it, avoid it, okay? Most of the time, for me and my comfortability, if I have anything that is not an A and a B in a pregnant person when I'm practicing, I will not give it. I'll tell them, hey, go talk to your OB about it. Because likely they have more experience because they see more pregnant patients than I would. So I send them there because that is who is over their care. So not a test question, but when you are practicing, anything that hits C down, try to avoid that. Send them back to their OB unless you absolutely have to and you don't have time, okay? When we look at our PLLR, or our new FDA pregnancy and lactation labeling rules, on this one, you see that you have these 3 subsections. So you have pregnancy, lactation, and females and males of reproductive potential. We don't have a whole lot of drugs that talk about like our males of reproductive potential, but we do have a lot of information that talk to us about like our females. Oh, avoid this medication while you're pregnant. Avoid this medication if you are trying to become pregnant. Avoid this medication for a cycle after, right? We saw some of that with some of our other meds that we were looking at with derm. So this is the same exact things that we already talked about. Now, when you see these subsections, you have further subheadings that are in here. So when you look at your subheadings, your lactation and your pregnancy both have the same exact subheadings: risk summary, clinical considerations, and data. And then you see that your females and males of reproductive potential, they don't have any subheadings that fall under that. So pay attention to how you would look at this. This is going to be with the package insert of that medication that you'll see the new PLLR, and every drug will have these 3 subsections: pregnancy, lactation, and females and males of reproductive potential. And then your pregnancy and lactation will have those subheadings: risk summary, clinical considerations, and data, okay? So this is let you know, can I safely use this medication in my patients who are pregnant? These are some of the things that we talked about in the very beginning that could happen when someone becomes pregnant. You can have these PK changes that happen, and one of the big things that gets affected is going to be absorption. So medications can potentially stay longer in your system. You can have where the concentration might be decreased because I have more fluid on me, so dilution. Or you can have where I'm going to the bathroom all the time, which also happens a lot, right? Because we don't have a lot of space. You have increased blood flow because now there's 2 humans that your body is trying to supplement for. So sometimes people will have increased blood flow while they're pregnant. Also have to think about if I'm sick while I'm pregnant, right? I might be throwing up medication. So am I going to absorb everything before it got broken down and distributed throughout my body? Depends on when I threw up. Depends on if I gagged when I was trying to take that medication that you gave me and then I threw it up. Not likely to have a lot of absorption there. So think about the condition as a whole and kind of how the body changes. This then will all kind of make sense for you. So decreased gastric emptying and small intestine motility, increase in gastric pH, nausea and vomiting, right? So therefore I'm not going to have a whole lot of meds being absorbed. And therefore when you see this happening a lot, even when we try to give them meds to stop the nausea and vomiting, you can get creative with how you're going to give things. So you have rectally, you have IV, sub-Q, and IM. So when you look at IV, which is usually what we end up doing, because people will go back in because they've been throwing up so much, they'll go back into their OB, what have you, and they're going to say, oh, you're so dehydrated. They hook you up, they give you fluids and all the things, and then they'll send you about your way. So just understand that if it is a medication that they're taking on a daily basis, you do have the potential to be able to give them a rectal or an injectable. If that drug has that formulation, you can go that route if your patient is okay with it. Inhalation, increased absorption, right? Because you have several other things that have increased as well. So if I have an inhalation drug, I have increased the absorption. In my IM, increased absorption as well, because again, I told you that perfusion and that blood flow has picked up. Renal flow is also picked up, their GFR. So you'll see a lot of that happening as well. What I want you to pay attention to is, again, all of these things are falling under absorption, right? So understand what happens if I'm like, oh, they have an inhaled drug. What do you predict is going to happen in that patient? Oh, if they have nausea and vomiting, what can I do, right? Is their absorption going up or is it going down? What are some alternatives that I have? Oh, let me give them a different route. Looking at your distribution, we already said that there's more water that's in the pregnant woman's body. So if I have more water, I could potentially have more drugs that are around that are free, that can bind. You see that sometimes with your albumin, you don't have as much albumin around at that time. And so therefore you can see an increase in your free active drug, right? If I like to be bound, now that's a property that depends on that drug though, right? Because everybody doesn't like to be protein bound. If I like to be bound, now I'm active because I'm unbound. Remember, are we in a relationship? We're not in a relationship. And if I'm unbound, I'm free. Now I'm active. I can go on my dates, okay? Your body fat increasing. Again, this shouldn't be a lot. Some people carry pregnancy weight different. You want to make sure that you're monitoring that when people are coming back to you if they are pregnant. Yes, they should gain weight. Should they gain more than this 4 kilograms? Not really, okay? You'll also need to watch that they are gaining weight because some people may not gain weight. Some people lose weight when they get pregnant because they're so sick. So that should prompt you to ask questions to make sure that they're getting the nutrients and everything that they need to support themselves and the baby, okay? Looking at your SIPS or your P450 system, you see that several different things can happen there. Not something that I'm going to really look at asking you about, but you can see the induction or inhibition happening because of those hormone level changes while they're pregnancy. So if I have an induction versus an inhibition, same principles that we've always talked about. Your elimination, again, we said that GFR gets increased, that blood flow gets increased. So therefore, you could potentially see where some of these medications are affected. The concentration will decrease because I'm getting rid of it quicker, okay? So decrease the maximum concentration of the drug because I'm eliminating it faster, right? I've sped everything up. This is just telling you that there are medications that, again, get to the fetus, okay? So we want to just make sure that you understand that babies are affected by whatever their mothers take. That's all I need you to know from this slide, okay? Babies get affected by whatever their mother, right, takes. All right, nausea and pregnancy and morning sickness. What happened? Oh. When you look at this, several symptoms, everybody does not present this way. You will have where sometimes someone will have a pregnancy and they're like, I felt a little weird, but now I'm okay. You'll have some people completely on the other end of the spectrum where they're vomiting all the time. Morning, night, doesn't matter. They can't figure out. There's no rhythm as to when they're throwing up. They can't predict it. Morning sickness is a term that we think usually happens in the morning, but sometimes it doesn't for everybody. So when you look at this, one of the biggest conditions that you're going to be treating in pregnancy, this is telling you what is going on. Now, nausea and vomiting, not the same thing. Nausea is just me feeling, like kind of how we say queasy, right? My stomach feels unsettled, but I'm not actually vomiting. That is the actual act of me like throwing up whatever I had, okay? So you can just, again, see nausea without vomiting. Just because you see nausea does not always mean that it will lead to vomiting, okay? When you're looking at this, you want to try to make sure that they're eating foods that are appropriate for them. So you can do the brat diet, which is bananas, rice, applesauce, and toast. Trying to avoid sugars, dehydration. This becomes very, very tricky because if someone is vomiting a lot, they may be experiencing, or if someone is nauseated and it transforms to them vomiting, they can become dehydrated. Sometimes people will avoid things because they feel nauseated and they're like, I don't want to drink or I don't want to eat because I don't want to vomit. So correcting dehydration is also very important because when someone is pregnant and dehydrated, they start to sometimes experience contractions, which also doesn't make you feel good. It makes you feel nauseated or it could potentially make you vomit. And then the prenatal vitamins, make sure that they continue to take those vitamins. Some of them are very large. They can buy some that are smaller, but these are things that you have to think about and make sure that the patient is actually doing, okay? okay? Because if they're very, very nauseated, again, that gag reflex, because they're taking a prenatal vitamin that's pretty big, they may not be taking their prenatal vitamins either. So just, again, conversation to have with them. If the nausea is very severe, these are different things that we can do. Make sure that you're trialing them, giving them some time to get to that steady state in their body. So we at least try to put them on these medications for a week. You may be the first contact that somebody has before when they find out that they're pregnant, right? Or they may try to get in with you because it's going to take a while for them to get to OB. So your starter pack when someone's pregnant, you're like, congratulations, you're going to get some pyridoxine and doxalamine is usually what we will tell them. Now, some people will start out with just ginger, right? We don't have this in the pharmacy, so we don't have this. They can go and buy ginger. They can eat it. So ginger and or pyridoxine, which is your B6. Most of the time when they take them together, it is more effective than them just taking it alone. When you see that someone is actually vomiting, you don't get a great benefit from the ginger. The ginger is just there to help if they feel nauseated. Now, when you look at your doxalamine, this can be added on to the ginger and pyridoxine because you can use them together or single, like individually. But then you can add doxalamine because I came back into you and I'm like, Doc, I'm still feeling super nauseated, like I can't do anything. Then you add doxalamine. If you don't have a response, then you're going to stop these. Oh, how did that happen? Oh my gosh. What do y'all see? It messed up on my side. Then you're going to, my mouse is gone. You're going to stop your 1 and your 2, right? So you'll stop these if you had no response, right? It didn't work. You had me on it for a week. Stop these and then I start my antihistamine. If I had a partial response, so a partial response is me saying, well, it worked a little bit, but I still feel nauseated. Then you can add the antihistamine to the stuff that we already know is working. So if it doesn't work, get rid of it. If it's kind of working but not fully, add to it. Okay? Now, when you look down here, this is usually where you're going to be working. When you get down here, this becomes more where there's nausea actually happening with the vomiting. Some of this you may not feel comfortable with, and so you could refer them if you needed to, but you also need to make sure that you stop the vomiting if they are vomiting. Okay, so don't just be like, well, wait until you can get with your OB because they're pregnant. They can become dehydrated, right? And that can become a problem for not only the mom, but also for the fetus. So now you see vomiting is happening in all of these, your 4 through 6. So adding a dopamine antagonist, which we're going to go over some more of these, but your metoclopramide, your promethazine, adding ondansetron, which is the same thing as your Zofran, or if it's very, very, very bad, you can add glucocorticoids, which we're going to talk about, but these are essentially your steroids, okay? They will be in the hospital, and you're going to have to give them these medications, all right? Come up to the mic. Yeah, come up to the mic so they can hear. Sorry. We have a question. Wait, everyone. Sorry. Yes. Turn it on. Our first question.
So when we're adding these, are we subtracting anything else, or are we just stacking them on top of each other?
Okay. Good question. So here, it depends. So 1 and 2 depends. So if you're at 1 and it's working or it's not as effective, you're still going to add on here. Right? So now I could be taking 3 meds, the ginger, the pyridoxine, and the doxalamine. Most of the time people end up with pyridoxine and doxalamine because the ginger is hit or miss on if it works. But testing purposes, I will tell you if they tried something, like if I were on step 1, right? And I was like, oh, they're taking ginger and pyridoxine, but they're saying that it's not working. Your answer is, okay, I'm going to add doxalamine to their treatment. Now, if I already had these things up here, whatever the combination may be, and I say they don't have any response at all, they're telling you it's not working, they feel the exact same as before you prescribe them these meds, you're going to stop all of those because they're not effective for me, and then you start your antihistamine. If I told you, well, it kind of works, I feel a little bit better, but not all the way, so then what you do is you can now have the antihistamine added, but what happens is you're allowed to do like a smaller dose of that antihistamine because you still have these meds working in the background, because they did work a little bit. Now, if I'm telling you I'm actually vomiting, right? Sometimes we still have the pyridoxine and the doxalamine still on board. When I progress to this, these medications are taken in addition to. On the exam, the way that if you have a question that it will be worded, it will be very clear and you will know which one to pick, okay? So a lot of times this is an escalation. Like they may be on number 4 as like maintenance, or to have it with them at home and it's not working. And then you can be like, okay, I can give them some Zofran to take home or your ondansetron, and they take that and it's still not working. This is usually like they're in the hospital because they're very, very bad. And most of the time these people are very, very dehydrated. Okay, so you start to add on to them. This is a picture of 1 through 6. Okay, so if you like to see it in pictures, it's the same thing of telling you, hey, what am I doing? Okay, so without vomiting and with vomiting, and then just going down this. What I will say is my 1 through 6 is very straightforward and basic, and I would look at the 1 through 6. Okay, this is going into detail that I'm not going to ask you, and you can use this when you're actually practicing. Okay, FYI. But it's a summary of 1 through. It's more detailed of my summary in 1 through 6. Okay. Now, ginger, pyridoxine, 2 things that we talked about. The ginger, I already said these things to you. I don't need you to remember any dosing. Your pyridoxine or your B6, good when we're talking about, again, that nausea, not helping with the vomiting, because remember, everything that was above that red line was focusing on nausea. Everything below it was, I threw up, okay? Your mechanism of action, it's a precursor, so therefore it helps with the functioning of like metabolism, several things. So again, make sure that you're looking at your mechanism of action for your pyridoxine. And then the big thing with this is the higher the dose that you give, you can potentially see neuropathy happening and maybe some drowsiness. But the dose that we usually give to help with that nausea in our pregnant women, you don't see those doses being that high, okay? So keep that in mind. So here, just understand ginger, pyridoxine, good for our nausea, right? Not helping with vomiting. Mechanism of action for your pyridoxine, and neuropathy. Neuropathy, high doses, neuropathy. This is an FYI slide, but you also have that acupressure point where you can try to have them pinpoint, and if they don't want to take medications, because again, that's their right if they're pregnant, they don't want to take medications, they can try to hit that pressure point and see if it can relieve the nausea that they feel. We also say sometimes that this helps with motion sickness as well. All right, your doxalamine or your Unisom. Antihistamine, I can get this over the counter. We also have it available for them. What this is doing is looking at that histamine receptor, okay, competing and blocking your chemoreceptor trigger zone, or your CTZ. Now that's what could make that patient feel nauseated, right? So that is why we get that benefit from having the doxalamine on board. And that's why you can see this used when we're talking about the B6, when we're talking about the ginger. This is one of those good options, okay? When we give this in the pharmacy, we'll usually tell them to break the doxalamine in half because it can cause them to be a little bit drowsy, right? So we try to say, hey, I know this is an antihistamine. Does anybody remember which generation? 1? Y'all like, no. When we look at this, right, go back to that, because that makes sense as to why we're doing the things that we do, but it does still hit that CTZ. So in my nausea, right, I'm nauseated. If you can hit my CTZ, that's going to help decrease that stimulation that I have, and therefore decrease the amount of nausea that I feel. When you look at this, don't worry about that, I'm not going to ask you that, your diclesias. So this is just a convenience. When you see your diclesias, this is your pyridoxine in conjunction with your doxalamine in 1 pill. This is a hit or miss on if it is on the formulary or not. Most of the time it is not. So what we do, you are going to prescribe pyridoxine, send that to the pharmacy, and prescribe doxalamine and send that to the pharmacy. And we tell the patient to take these 2 things together, right? It's still the same thing as what this brand name is. The composition of it is the same. The issue is that TRICARE sometimes does not pay for it alone. and you see that the effectiveness is better than you using either of them just by themselves. Don't worry about that. Not going to ask you about something that previously happened. All right. Looking at my persistent, again, you have your antihistamines that you can use. So you had your doxylamine and your pyridoxine. No response. This is the same thing that we talked about on step 3. You have your dimenhydrinate and you have your diphenhydramine. If you are going to use your diphenhydramine, please stop your doxylamine if they are still on that, because now you are going to increase the chances of what? Sedation, right? Because they're both antihistamines and they both have a high chance of causing sedation. So now you could potentially increase that, increasing the risk of side effects if you have both of them on board. And then looking at your meclizine, we still use it, but we did see that there's an increased risk in the fetus developing a cleft palate. So clearly we have better options that we can use. So go with one of those. A lot of times now you'll see some doctors using the dimenhydrinate, but patients can easily have access to the diphenhydramine, so we still use that as well. Looking at my dopamine antagonists that I have, essentially what these are doing, stimulating that gastric motility, right? Emptying to decrease the emetic effects. So what I'm trying to say, right, I don't want to actually vomit, because now we're at 4. Remember, everything that was under that red line, I'm actually now vomiting. I'm actually throwing up. So now your target is to stop the vomiting. 1 through 3 was nausea. 4 through 6 is vomiting. So looking at this, also trying to decrease the signaling that's telling me that I need to throw up. If I can block that signaling, then I'm not going to throw up. My body is not going to be able to transmit that to the brain to make me actually act on wanting to vomit. All of these have good efficacy. Picking one, it doesn't matter which one you pick. So you have your metoclopramide, promethazine, and your prochlorperazine. This is going to depend on how the patient responds to the medication, and also if they're already experiencing sedation and how far along in the pregnancy they are. Because sometimes when you're pregnant and you're making a whole human, you're sleepy anyway, right? So now you're giving me meds that could potentially make it worse. So when you're looking at your metoclopramide, long-term use, you see that it can cause TD. May be irreversible if we don't catch it in time, but a lot of our pregnant patients, they have several appointments to where it shouldn't be far along if they're getting proper medical care for us to catch that. Your promethazine, again, you see that we still have some dyskinesias that could happen because, again, remember our dopamine. See, this is where y'all have the advantage over here, right? Because y'all just did this. Y'all need to go back and remember what your dopamine receptors are doing, right? So when you look at that, that's where you start to see those issues, right, with movement. Remember that when we talked about Parkinson's and all the good stuff, right? Still no? Okay. So with your promethazine, you also see that we can lower the seizure threshold. What other drug did we talk about a lot that lowers the seizure threshold? I don't see no mouths over there. They're like, you can't hear us anyway. So ibupropion, right? So mother and baby. This becomes critical because we don't know if that baby has any issues yet, right? So if I'm lowering the seizure threshold of a baby, brain damage could potentially happen there too, especially if they're seizing inside their mom's belly, all right? Your compazine that you have, again, same side effects, so just pay attention to your side effects. We don't have a lot of large studies that show us that there's any type of deformities that can happen, but they do have case studies where they go back and they look and they say, oh, maybe in this small population, which is what our case studies look at, like in this small population or in this individual that we were following, we saw that there were some issues in the infants once they were born. But again, big studies, we don't have any of that happening. Looking at your phenothiazines, you have your prochlorperazine and your promethazine. Very good medications, both of them. They're helping with that nausea and vomiting. When you're looking at your promethazine, you see that you can also use this when we were talking about motion sickness, right? So nausea and vomiting for both of them, but motion sickness here. When you're looking at your preference, it depends on the setting that the patient is in, but you can give them that IM. Very rarely do you see us use this in that IV formulation because there's a lot of things that can happen in that tissue necrosis that's also a possibility. Mechanism of action, your dopamine, muscarinic, and histamine receptors are being blocked in the CTZ, and remember that's what we were worried about if they had nausea and vomiting, so you're able to target that. And then looking at your sedation, they also have histamine effects as well, so you can see that the drowsiness and the sedation coming from there. Adverse effects, let me talk about the clinical use. So the clinical use are the things that we talked about up here when we looked at the products, and then chemo-induced nausea and vomiting. So if you have a chemo patient, a lot of times, depending on what type of chemo regimen they're on, they will have and experience a lot of nausea and vomiting. And remember, they're also very immunocompromised. So we can pre-treat them with some of these medications prior to their chemo infusions to help them not be as nauseated or potentially vomit. Adverse effects, hypertension, restlessness, EPS, drowsiness, the typical things that we see that we kind of already talked about when we were looking at our phenothiazines, because we saw these before as well. Serotonin antagonists. So again, this was like a step up. So you would likely be in 3 for prescribing things. When we start hitting 5 and 6, this is where sometimes you want to make sure that you have experience. You want to talk to OB if you can. So looking at your Zofran, we do see that it's better than the metoclopramide that we talked about, but there is a lot of back and forth on what should be done and if we should be prescribing it during pregnancy, because we don't know the safety profile of it. There have been times where this has been given to pregnant women safely. So again, this is one of those ones where if there's confusion and somebody is pregnant, the way that I practice is, well, let's call OB. Let's talk to your doctor and see what your doctor recommends, okay? Adverse effects, see that some stuff is very mild, right? Headache, constipation, the basic things that we see. A bigger deal that we can see is that QT prolongation when we're talking about our ondansetron, okay? QT prolongation, big thing. Retrospective, so this is saying after, right? Somebody had a child, what we do is we would go back into their profile and say, hey, have they taken Zofran while they were pregnant? So what you're seeing here is that they did a study and they didn't see any increased risk of those malformations that were happening, but they did see the cleft palate, the oral clefts happening in those patients. But again, this was in the first trimester. Now, if you think about that, when people are usually having nausea and vomiting, it's in the first trimester, right? So this is usually when they need it. The patients who are, like I told you, you will have some patients who are sick the entire pregnancy. That's usually when we reach in the bag and we're trying to use this. Granisetron, not something that we use a whole bunch. We use our Zofran a lot more, but side effects are very similar. Just know that it exists. Big thing I want you to remember, these have that QT prolongation. Iffy on if we should use them, okay? Your glucocorticoids. Now this is, bless you, way further than where you should be. This is usually where your patient is going to be. Sometimes in the hospital, we want to make sure that we're avoiding it in that first trimester. So this is like we've tried everything else. It didn't work. Refractory, right, means that everything else that I had prior to did not work. I have my methylprednisolone, my hydrocortisone, and my prednisone. Again, we're going to do a burst. We're trying to get them on something to control that nausea and vomiting quickly, and then we're going to take them off, okay? Adverse effects that we talk about when we look at our corticosteroid lecture are going to be the same ones that you're going to see here. So not going to go into detail about it. We're going to get that in our next lecture that we have. Looking at our GI issues and pregnancy. I'm going to keep going. So if y'all need to use the bathroom, whatever, you can just walk in and out as you need to so that we can try to not have to do tomorrow. Okay, so I'm going to just keep going. I'll probably take a break for 5 minutes for myself in a minute. So your step approach for if somebody has gastroesophageal reflux, right? When we talk about reflux, this is something that can happen and get worse as the baby starts to get bigger. I'm losing space, right? So my food and me digesting it and trying to get things and absorb them right in time, stuff starts to slow down as I start to grow. So when you look at this, smaller meals, don't eat spicy foods, these are things that can cause reflux in themselves, right? Without somebody being pregnant. Elevation of the bed, not eating late at night and then laying down, all of those things could make someone, especially when they don't have as much room, feel like they're having reflux and they want to get rid of their food. So my options that I have: antacids, sucralfate, H2 antagonists, and my proton pump inhibitors. This should be a review because y'all saw this last semester. Y'all saw this in Pharm 1. Was that like, what, a month, less than a month ago, right? Last week. That was an angry last week. All right, so our antacids that you have, you see for the most part that they're pretty safe. When we're looking at your aluminum, remember that we said aluminum and calcium constipates. And then looking at your magnesium makes them go, right? Diarrhea, okay? Looking at your sucralfate, you see that because we don't really absorb a lot of this medication, it's very good and safe in our pregnant patients. Again, just helps the gastric lining be coated so that they don't feel like they have that reflux or that urge to throw up. A big thing that I want you to make sure that you remember here is that if you pick an antacid or if you recommend an antacid, don't recommend an antacid for a pregnant patient that has aspirin, because we don't use aspirin in kids, right? So if they're using a bunch of antacids that have aspirin while they're pregnant, remember I said whatever goes into that mom, some of it is getting to the fetus, okay? So just be very cautious when you're advising that and make sure that your patient knows that. The same thing with like topicals that they put on, because those can have aspirin in them too. Looking at your H2 antagonists, you've seen these. You have cimetidine, which is the one that we have a lot of safety data on, but we do use famotidine quite a bit. It's gaining more research, gaining more popularity. So this would be one of those things that you would do more research on to see what's going on. Now, if I'm looking at cimetidine, it's an older drug than my famotidine, but when I look at it, also you see like excreted in breast milk, not recommended if someone is breastfeeding. So in my mind, when I think about that, I'm more likely to pick famotidine over cimetidine, but either one is an option for your exam. Either one is an option. Looking at your proton pump inhibitors, don't have a whole lot of studies that's talking about it, but again, safe for us to use. The more popular one that we usually are prescribing is going to be your omeprazole, but we do have lansoprazole, pantoprazole. Remember, a lot of these also are available. Some of these are available over the counter for the patient as well. But again, you've seen these drugs, just looking at them and understanding that these are great options for pregnant women with GERD. Constipation. When you look at your options that you have, you need to make sure that they are hydrated, right? So fluids, exercising. Just because they're pregnant, you want to try to encourage movement, because the more that they sit, the more that poop sits, okay? So the more that they move, the more that their body is going to move, all right? You also have your fiber. We talked about this in that GI lecture as well, right? So you have your bulk forming agents, your stool softeners, laxatives, whether they're osmotic or the stimulant laxative. When you look at these things, I want you to be familiar with what they are called, right? And then, are they safe? All of these are essentially telling you, yes, they are safe, but you want to start up here with your bulk forming or your stool softener, okay? These down here, the more aggressive you are with treating the constipation, the more likely you are, like let's say you overshoot or the patient overshoots, right? They use the osmotic or a stimulant laxative, and now they're going to the bathroom. They can't stop going to the bathroom. They were on the verge of dehydration, and now they're dehydrated, okay? Electrolyte imbalances, all of those things can happen with the dehydration, so that's why we're worried, because they're pregnant, okay? So start here at the top, your top two, and then your laxatives are your last line, kind of refractory, nothing else worked. Diarrhea, looking at this, again, trying to make sure that we are focusing on diet, hydration, all of the good things, right? Electrolytes. When we look at this, you do see that with loperamide, which is what we would typically think to use, we don't have great studies that show if it is harmful or if it's not harmful. So when you look at this, just make sure that you understand that we are not using the bismuth subsalicylate. Why not? Aspirin, okay? That's the big thing I want you to know about this when we're talking about diarrhea in pregnancy. So here, I don't see any teratogenicity. This is the one thing that we typically can see potentially use, but do not use your subsalicylate, because this portion right here, your aspirin. All right. Other issues. So as you go through this, I want you to look at the title of what the slide is saying, and then I'm going to tell you what I need you to remember, and what will, like testing purposes, what you're likely to see. So pain and fever. For this exam, and staying in this classroom, they use Tylenol, okay? Not getting political about Tylenol. They use Tylenol, okay? Anything else, any other NSAIDs, all of the other things, no. So if you see anything else about pain or fever in a pregnant person, Tylenol. That's what they earn, Tylenol. That's it, okay? That's all this slide is saying, this entire slide. Don't use NSAIDs, Tylenol. Pregnant, pain, Tylenol, okay? When you look at your cough and cold meds, your antihistamines that you have, we keep seeing Benadryl pop up in several different ways, right? Multiple ways to use it. Can't go wrong with Benadryl. So you have your diphenhydramine that you have, and then your loratadine and your cetirizine. These are things that you see us using a little bit more because they don't have as much of that drowsiness as the diphenhydramine. So that's the big benefit that you get here. Looking at cough suppressants, it's kind of like telling us we don't have anything, okay? So am I likely to ask you about a cough suppressant? No, okay? So here, antihistamine, look at the top things that are in bold, okay, for your antihistamine. Cough suppressants, we don't really have anything that's great. Cough and cold again, so runny nose, sneezing, I have throat pain. Saline, remember we talked about saline when we were talking about allergies, and we said this was good in my elderly patients, we said that this was good in my pregnant patients. So here it is again, just making sure that they use clean water. Your decongestants, when you look at this, it could, again, we talked about decongestants and how some of them increase their patient's blood pressure, right? This could also be potentially already happening in someone who is pregnant, because I told you all of these things are speeding up. Their body is changing consistently. And if I do that, I can decrease fetal blood flow, which I don't want to do, right? Another human, they need that blood flow going. So when you look at this, you see that we try to avoid them, especially in that first trimester. You can potentially see where you use these short term. I err on the side of calling the OB for this as well, but it is possible for you to short term give like an intranasal, because if I'm talking to you about things that are nasally happening to me, for the throat pain, again, we just go back to the Tylenol. But you can use intranasal oxymetalazoline, which is the same thing as your Afrin, right, that you could use for your patients. But again, making sure that they're staying under that 3 days is going to be very important. Now, with pregnancy, some people are also just congested because of the pregnancy, right? Everything has sped up for them. And sometimes you will see that. So you have to make sure that you're counseling them on not using this over that 3 days. They will try to use this a lot sometimes because they are congested and they're uncomfortable, right? So make sure that you counsel them on the 3-day limit. That is a big deal in this situation, because they can, again, have that congestion without the pregnancy, with just being pregnant and not being sick. Okay, this is an FYI slide. It's just telling you about preeclampsia. I'm going to tell you what your patient has. When you look at this, I want you to focus on the treatment. So, lifestyle changes, that's the big thing that we're telling them the entire time. So our meds. When we look at our meds, you have labetalol, methyl-dopa, a couple other meds that we use, but labetalol, methyl-dopa. If they are in an urgent or emergent hypertensive situation, we have labetalol, hydralazine, and nifedipine that can be used in those situations. I will specifically just tell you that's exactly what it is. When we get to hypertension and we start talking about some of these things, it will make more sense to you, because you're going to see some of these meds come up again, okay? So all I need you to know is like, oh, preeclampsia, what treatments do I have? Okay, is it chronic hypertension, meaning they hit that, we diagnose them with preeclampsia, and now they're having to take a medication every day until they deliver that baby, and sometimes a little while after they deliver that baby. That's chronic hypertension. Or I could have had hypertension prior to me getting pregnant. You had me on some other med. You will need to switch me to one of these, because this is what is safe in pregnancy. And then looking at your urgent, emergent, We'll talk about this again later blocks, but these are our different options that we have there: labetalol, hydralazine, and nifedipine. Eclampsia, again, just remember the condition. And then when we look at our treatment, magnesium sulfate, this is going to be given IV. Make sure that you're paying attention to the route, the fact that I have to give this IV, and it's magnesium sulfate, okay? This is going to be the drug of choice when we're trying to prevent seizures, if we think that they could potentially have a seizure because of the eclampsia. So eclampsia is happening because someone probably had preeclampsia or they had a history. And so what we do sometimes prophylactically, depending on what that provider wants to do, is that we'll run the magnesium sulfate. What happens if they don't have the seizure and I was running my magnesium is muscle weakness, fatigue, confusion. So it's kind of the trade-off of you don't know if it's going to happen, but if a seizure happens, it's a little bit worse than the muscle weakness and the fatigue and things like that. They're going to be in the hospital anyway. And then I want you to pay attention to the antidote. Don't worry about how we're giving it or any of that. And then your antidote, you have your calcium gluconate, okay? If you gave it and they're telling, like now you see like, okay, we're in the safe zone and they're hitting that muscle weakness, the fatigue, calcium gluconate is what would be on board. So your antidote for your magnesium sulfate, calcium gluconate, and you're using this for eclampsia. HELP syndrome, when we look at this, you see a lot of this is going to be supportive care for your patients. Back and forth on steroids, so I'm not asking you about steroids, not going to ask you about a transfusion. So just understand that this depends on the patient and what's going on. FYI, not asking you about HELP syndrome. Looking at gestational diabetes, we're going to talk about diabetes. I'm going to tell you that the patient has diabetes or gestational diabetes. What we want to use and the most effective treatment that we have is going to be insulin, which is an injection. That patient is going to have to inject themselves before meals, likely every single day, okay? So this is what is our preferred medication, insulin. When we look at some other options that you have, your glyburide and your metformin, we have seen these used. These are oral options that our patient may be having. This is like second line. Your first line thing, your preferred thing that you want to do is insulin. Because as that woman's body changes throughout the pregnancy, you can change the dose of the insulin, okay? It's easy for you to titrate it. It's easy for you to say, all right, give yourself a larger injection today than you did yesterday, versus trying to bring them in to change doses of tablets, okay? So glyburide, metformin, second line type things, insulin is what we prefer for gestational diabetes. Neural tube defects, folic acid, that's all you need to remember, okay? They need to have folic acid. If someone is planning to become pregnant, you can give them a prenatal before they get pregnant, which has the vitamins, which has the folic acid, and some of them have DHA in them. So like there's several different things. We are essentially with a prenatal trying to get the body ready for the pregnancy, okay? And that these have folic acid in there. So before and throughout pregnancy to prevent the neural tube defects. When you look at anemia, different irons, you guys are going to talk a little bit more about this later, but you have ferrous fumarate, sulfate, and gluconate. The percentages that you see are just the different amounts of elemental iron, not going to like trick you and give you random percentages of iron with the wrong drug. Just know that you need iron. They all start with ferrous, okay? Ferrous something, fumarate, sulfate, gluconate. Side effects, the big thing that you need to make sure that you're telling your patients is that their stools will become darker and they may experience constipation. A lot of GI issues when we talk about the iron supplements, okay? Let them know dark stools are the problem. Are they harmful? No, it's just the medication, okay? Looking at this, you can, FYI this slide, this is just telling you that meds, right, can go into the breast milk. That's why we look at the PLLR to see, hey, is this going to affect the fetus if somebody is taking a medication in their breastfeeding. When you look at your antihypertensives, you see that there are a lot of different meds that we can use. This is saying, hey, I'm pregnant, what can I use? The big ones that I want you to remember are these top three, okay? And I remember like Lifetime Movie Network, labetalol, methodopa, and nifedipine. If I'm pregnant, I want to watch soppy movies. Okay, Lifetime Movie Network. Labetalol, methodopa, nifedipine. These are some other options. There's just nuances to them that we don't need to, I want you to know the main things that we look at. Okay? Avoiding your beta blocker, ACE inhibitors, ARBs, we're going to talk about this because of the order of things now. Just Lifetime Movie Network, antihypertensives. That means I'm telling you your patient has high blood pressure, you need an antihypertensive. Okay? Antacids, reflux, upset stomach. Avoid anything that has aspirin in it and you're pretty much okay, right? This is a summary of what we already talked about. So if you see anything that says aspirin, anything that has aspirin in it, no. All right? That's all this is saying. And then also looking at the sodium bicarb, make sure that you remember not to do that as well. You can get alkalosis and things like that in the mom. Lots of problems. So sodium bicarb and anything that has a salicylate in it, you don't want to use it. Antifungals. Make sure that when you're looking at this, and the easy way that you can remember this, anything that is once a day, like they can go in and get it and have it take one dose, right? I can use it for one day. It's not good for pregnancy. And the way that you can remember that is that dose is probably very, very high, and now I've increased the chances of it getting to the fetus, is how I remember. So anything that I tell you that they can use, it needs to be 7 days, right? So you see 7 day, 7 day. This is topical, I'm fine with that, right? Systemic absorption, my barrier, and going through the skin might not be such a big deal. And then when you see your fluconazole, which we use a lot in the general population, right, for a lot of our antifungal infections, here it's a maybe, okay? So if I have maybes versus 7 day vaginal preparations, I'm going to just use my 7 day vaginal preparations, okay? No 1 day. So anything that you see that says 1 day, no, okay? Not good for pregnancy. Looking at some of these topicals, high potency steroids, retin-A, these are things that we already talked about, so you can just FYI this. I'm not going to ask you this way. You're going to potentially be asked in other ways, right? We've seen this already. Our antibiotics, let's just FYI, because why not? Let's FYI it, all right? Y'all are so silly. And then when you're looking at your antivirals, everything is pretty safe for us to use in pregnancy. The only one that you see that's bad is your baloxavir. The B is bad, okay? That's the only antiviral that we're not using. And then memory jog, again, going through here and reviewing all of these things. That's it. Let's take 5 minutes, come back. So actually come back at 2:15, so 14:15. All right, party people. Steroids, they finally showing up. So we talked about them. There's some background info on here, and I'll tell y'all again, like I've been doing, on what to hear and not to hear. Somebody came, people were asking like, are you giving us hints? I don't know. Okay? You. Nah, see, now I'm going to have everybody looking at you. No. So listen, I know that it is a lot of information. If y'all are worried about how to organize and study it, you can talk to me about it. I will be in my office. Whenever I'm not having y'all in here and lecturing to you, it is to give you time and also access to me. Like I'm around. I'm just moving around sometimes, but I'm around. So if you text me, I will be where you need me to be when you need me to be there, okay? So if you want me to look over something to be like, hey, is this the right direction, because I know everybody's nerves are bad, then I can do that. But I also want y'all to remember, you cannot study this class and be nervous, okay? I want you to have fear, but you have to be able to process the information. A lot of times when people come in and they talk to me, and I talk them through a question, or we talk through it, they can answer it. but they're so panicky during the exam or while they're studying and freaking out. I'm getting text messages before the exam. I might fail, so just look out. Like, don't do that. Don't do that. Don't ever do that in life, okay? Like, be confident. We're gonna make it through. Just don't do that, okay? If y'all are worried, let's talk about it. Let's find a constructive way to get to where you need to be. But I want you to be able to absorb what you're looking at, all right? Okay, steroids, same ELOs that we've always talked about. Here are some of the meds that you're gonna see as we go through this. Now, when we talk about, this is FYI, by the way, not asking y'all this on an exam. When we look at this, okay, you have glucocorticoids and you have your mineral corticoids. Let me get my mouse. So when you look at your glucocorticoids, the major glucocorticoid that we talk about is cortisol. That's why I have the CO underlined. Your major glucocorticoid is cortisol, which is we also call hydrocortisone, which we kept talking about, right? Y'all heard about hydrocortisone. Then when you look at your mineral corticoids, you have AL underlined because your major mineral corticoid is aldosterone, okay? So when we talk about aldosterone, we'll talk about how it helps with regulating our sodium, what we're retaining, fluid retention, things like that, and we'll get more into this in a different block. But sodium retaining is what you see with your mineral corticoids, and your main one is your aldosterone. Your glucocorticoids, your main glucocorticoid is cortisol, okay? You see that we need it, right? We need steroids. It helps us build cholesterol. It's a big building block and a big part of us having cholesterol, which is what we need for life. FYI that, FYI this. All right, so when you look at this, this is, again, a negative feedback system that is very important whenever we're talking about our steroids. So remember we said that glucocorticoids, right, is what we're talking about here because I have cortisol as my end result. So you have the hypothalamus, which has your corticotropin releasing hormone that stimulates your anterior pituitary, which then releases your adrenocorticotropic hormone, which stimulates the adrenal cortex, which then results in cortisol. This is your end result, right? When I have enough cortisol, I have a negative feedback system that will either go to my anterior pituitary or my hypothalamus and say, stop, I don't need any more cortisol, right? The more cortisol we have in our body, sometimes the more damage. They're doing lots of studies now, and they're seeing that it's related to so many things with high levels of cortisol. So this HPA axis being suppressed will be a big deal. Now, I told you here that my glucocorticoids, I'm looking at cortisol, right? So if I exogenously give this to you, if I give this to you with a medication, I am supplementing for cortisol that my body naturally made. What does my body then do? I have enough cortisol, it goes and it shuts things off. So when you kept hearing HPA axis suppression, that is because now I have continued to give my body with my medication, with my steroid, I was supplying the cortisol. And I told my body I didn't need it anymore. So that's why when we talk about cortisol and when we talk about our steroids, that's why we have to taper them off. We have to tell the body, hey, wake back up. You got to start doing your thing again because I'm taking this away from you. Now I need you to do it again. Okay? So it's like if I kept cleaning up my kid's room and then I shut off and they're used to me cleaning up their room, they're like, wait a minute. Who's supposed to do this? I don't know how to do that, right? That's your body. I don't know how to do that. You've been giving it to me. So that's why we try to do bursts. That's why we try to not have this on for a long period of time. And that's why we taper off, right? Because my body has shut down if I supply this through negative feedback, okay? Keep this in mind as we go through here. So glucocorticoids, again, cortisol. We have several different things that we're looking at here. So when you look at your adrenocorticotropic hormone, this was a big thing and why we try to say, when do you measure it? If you have a patient in the hospital, you're trying to measure in the morning because that's when you're likely to see these peaks. Okay, that's when a lot of our cortisol is going to be released. You get more accurate readings from there. Then you have your corticosteroid binding globulin. When you look at your corticosteroid binding globulin, the things that I'm drawing your attention to are going to be right here. If someone is receiving estrogen, contraceptives that we talked about, right? Menopause, hormone replacement therapy, or if they are pregnant, what we just talked about, you can see that I have an increase in my corticosteroid binding globulin. When you look at hypothyroidism, so my thyroid levels are too low, hypo is low, or if I have protein deficiency, you can see where in those situations I have a decrease in my corticosteroid binding globulin. So know what's happening there, because these things matter, and therefore you can have either less free glucocorticoid because it's bound to something in this situation, right? Because I have more corticosteroid binding globulin, therefore I have more of a binding capacity now. And if it's not free, then what does my body use it, or is it now it's occupied, right? It can't actively go and do anything. Whereas when I look at hypothyroidism or my protein deficiency, now I have a lot more free drug because there's nothing for it to bind to, okay? So kind of keep that in mind. So you have more free glucocorticoid running around, and therefore your body now is likely to stop making cortisol because it's all out, it's active, okay? So I want you to pay attention to this because these are common things that you can see that's happening, right? You can see pregnancy, you can see somebody on some type of hormone replacement therapy, you can definitely see hypothyroidism. All right, mechanism of action when we're talking about our glucocorticoids. When you're looking at this, you have a lot of different things that are affected when we talk about our steroids, because remember, these are a part of our body, right? They're building blocks of that cholesterol. So when I look at this, I want you to make sure that you understand that they're influencing several different parts of our body. A lot of metabolism gets affected when we're talking about steroids. Our blood, inflammation, there's so many different things. So when you look at these different things, the metabolic effects, the hematopoietic effect, the anti-inflammatory effect, these are the things that I want you to remember for the mechanism, okay? So metabolic effects, you see that I can have gluconeogenesis that's happening, my protein catabolism, right? Kind of not a good, we don't want this to be happening. Hematopoietic effects, if you just remember the titles, that is good enough for me for when you're looking at the mechanism of action and what's happening, okay? Anti-inflammatory effect. Oh, wow, look, we saw this, right, when we first started this block. Same thing, what you see here is these corticosteroids are trying to block that phospholipid from being cleaved and making the arachidonic acid, which then goes down and causes our inflammation, the bronchostat, all of the things that we talked about, which is why you see we can use steroids in all of these conditions. That's why we had that burst that we were using them for, because it's helping with that inflammation, because I'm stopping this cascade very, very high up, okay? So inhibits that phospholipase. So I guess the one thing that I want you to remember that you're likely to see in exams will ask you is this second bullet under anti-inflammatory effect. Okay, the indirect inhibition of phospholipase alpha 2, blocking the release of arachidonic acid. Okay, but everything else, just remember these titles, and that's good enough. The only one I want you to go into detail with is that anti-inflammatory effect. Okay. So when I look at my clinical use, we kind of talked about a lot of these. We said that we use these steroids in so many places, right? So if I look at this, inflammation, allergy, autoimmune disorders, that's what we have been talking about so far. My derm conditions, we talked about that, right? We're not going to go into detail about cancer, but we can also use these in cancer, adrenal insufficiency, or Addison's disease. You'll see that those are the main ones that I'm going to ask you about, okay? What's underlined? What is underlined? Bless you. When we look at this, this is a summary chart again showing you the indication, right? Clinical indication of the different things that I have to be able to use these medications for. Derm, nausea and vomiting, like the chemo-induced nausea and vomiting that we talked about. So if you want for you to remember this in the future, CINV is how you will typically see this abbreviated, the chemo-induced nausea and vomiting. Room disorders, so like this is the same thing that we saw here with the clinical use, the autoimmune disorders, allergies, inflammations. This is the same exact list, And we've already talked about this. We covered COPD. We covered asthma. When we're looking at the acceleration of lung maturation, this is when somebody is probably going to deliver early for whatever reason, or they have a premature child. Their lungs may not be developed, so what we do is we try to give them a steroid to try to help their lungs mature a little bit faster. Sometimes we do this while the mother is also still pregnant sometimes. So on here where you're seeing the preferred, this is a good summary for you to look at, because this can be an easy way for you to answer questions if you have a question on this. All right? So look at your preferred, but as we go through the slides, you're going to see these again. And a lot of these, we already talked about them when we talked about that specific disease state. Okay? Inhaled corticosteroids, we talked about them. Systemic corticosteroids, we talked about them. Topical corticosteroids, we're going to get more into them. We kind of glazed over them a little bit when we were looking at derm. So when you're looking at your inhaled corticosteroids, big thing here, not using them alone for exacerbations, but we talked about them with our COPD and our asthma. That's where we're using them. Systemic corticosteroids, we talked about them with COPD and asthma when we were giving them a burst, right? My inhalers weren't working, and so I needed to give them a burst of the systemic oral formulation of a steroid. So you see that I have quick resolution. So within 1 to 3 hours, I'm seeing some resolve in that asthmatic flare that patient has, which is good. They can't breathe. I want something that's going to work very fast. But maximum benefit takes a little while longer. You see that we have prednisone and prednisolone, and then your IV. This is if like you feel like they can't breathe. I need something that is going to be very, very quick. They can't swallow pills because sometimes people have a lot of constriction. If they can't swallow pills, you do have the IV formulation. So your IV is I need like immediate help right now. There's no access. They can't swallow any tablets. I'm IV, severe. And I will tell you if it is severe versus, oh, they're not in any imminent danger, severe. If they're not severe, right, I can just give them an oral steroid. If they are severe, I need my IV formulation of my methylprednisolone, okay? Your topicals, these are the things that we talked about with that inflammation when we were looking at derm. We had eczema, we had dermatitis, several different things, but we talked about different potencies in which we could use in those different vehicles that we could use in those patients. Could potentially make acne worse, rosacea worse, fungal infections worse, because we're going to talk about how these are some of the adverse effects that you can see with steroids, especially when they use them for a longer period of time. So when we talk about steroids, they can increase oil production, so that's why you can see the worsening of the acne. You see that the immune response can be weakened, so that's why we see these warts, these fungal infections, ulcers, things like that. It's hard for them to fight off because they've been on a steroid for a longer period of time. Also, you'll see the ulcers and things like that because they have delayed wound healing whenever they're using steroids. So just kind of keep that in mind. The longer they're on them, they might bruise a lot easier. Their skin will look a lot thinner as well. When you look at your inhaled, now pay attention because I went through and I underlined so you can remember which adverse effects you are seeing with which formulation. So your inhaled, we already talked about these. We said that we would use a spacer because we were worried about the fungal infections, right? The candidiasis or that thrush. Making sure that you're telling your patient to wash out their mouth, wash out their delivery system that they had with that corticosteroid that they had on board. In our children, the higher the dose, the more likely we were to see that growth suppression. Does this look familiar? Y'all are looking like we know this, okay? Well, you're about to know it. That's how y'all are looking like. We're about to know this. We heard this before. Larger doses, more likely to experience those systemic effects, right? It's going to go outside of the lungs at that point if we give them a very, very large dose. Another thing that I wanted to make sure that I reminded y'all about, remember when you go through the Pharm lecture, making sure that you understand when we wanted to use steroids versus like when we were trying to avoid them, right? So when we were looking at asthma, we were like, okay, I might need them. Like, kind of remember the difference of when you're using which things as a backbone when you go through that lecture, that Pharm lecture, okay? Understand which drugs are specifically for COPD, which drugs are specifically for asthma. Short term versus long term. So when you look at your short term, this is now systemic. I took a pill, oral, okay? When you look at short term, this is saying that something is either they had a very high dose of a burst or they didn't use it for longer than 2 weeks, which we definitely try to avoid. You can see the acne being worse. You will hear some people talk about mood changes. Weight gain could potentially happen, but it shouldn't be a lot because they won't be on it. But again, if they have a very, very high dose, because they won't be on it for a long time, you're not likely to see a whole lot of that. The other things that you see listed here, GI issues, main things. Y'all are going to see this slide. Okay, I'm telling you, you're going to see this. So you need to remember this. You need to know this. It pops up several times in several lectures. Y'all are going to see this. Your long term. This is for your patient who is on it every single day. They might be on it for a very long period of time because they have a chronic condition. So that's why when we were talking about things in that derm lecture, we were talking about steroid sparing and why it was important. This is why we have these long-term effects. So osteoporosis, glaucoma, their diabetes can be messed up. So hyperlipidemia, growth suppression, all of these things can happen. My mood disorders. Something that's not on here that varies on patients is insomnia. You can have some people who will take a steroid and literally after 2 days, they're like, I cannot sleep. That is from the steroid. For you, if they come back to you, some people, they just deal with it. But if they come back to you, what you can try to do is see if you decrease the doses that make it better for the patient. But please write in insomnia because that is something that a lot of patients do bring up that we don't talk about enough. It is a real thing that they feel. This one is topical. Okay, so these are my ointments, my creams, my foams, my gel, all of my steroids that I could use topically. These are different things that I see, right? So the bruising, told you about their skin kind of happening. These striae, these are likely irreversible, and you can kind of see where their skin gets pretty messed up. They kind of have those striae on them. Also, you can see where they can have atrophy sometimes. Most of the time, it's going to be on their face. And what happens there or wherever they're applying it topically. And what happens and what we can do to kind of fix that is to give them some of our retinols that we had, our retinoids that we talked about in the derm lecture. That's how we try to combat that. Spider veins, just all of the things, right? Not great. So that's why we don't want to use a high or medium potency on the face, right? Baby face, tender skin, okay? Low potency when we're looking there. You also see the contact dermatitis, hyperpigmentation, photosensitivity, several different things. Again, this is something that you guys are going to see. Cataracts, glaucoma. Remember the side effects of steroids because they're something that you are going to prescribe a lot, and the longer that you leave someone on them, the more likely you are to see these effects occur. This is called cushingoid. This is something that happens to patients, or how you can tell if they are either naturally producing too much glucocorticoid, or you gave them a medication and you gave them a dose that was too high. This is usually how they present. So these are several of the things that we already talked about, but it just has this little acronym next to it, right? So diabetes, depression, we talked about different infections happening. So these are all of the same things. This is, again, you having to test to see if there's anything else going on, like do they have any type of disease that we are needing to help them with, or, hey, do I need to decrease my dose because my patient is super sensitive, all right? This is looking at what we do when we're talking about our glucocorticoids and what happens with that HPA axis suppression. Because I'm giving you the end result, you don't have to work for it, right? I have an inheritance. You're giving me the cortisol. I don't need to do anything for it, right? I've turned into a brat. That's what happens. Our body turns into a brat because my HPA axis doesn't need to work. You're giving it to me. When we do that, high doses or longer durations, everything shuts down. When you are trying to stop that, you need to try to taper them off so that the body wakes up, which is what we were talking about in the beginning. So underlying things are what I want you to focus on. Tapering by 5 to 20% every 1 to 2 weeks. If you see symptoms occurring, those flu-like symptoms right here, you increase their dose back up and slow down the taper, okay? So where I'm saying every 1 to 2 weeks, maybe now it needs to be every 3 to 4 weeks. And every time those flu-like symptoms hit again to that patient, you increase the dose back up a little bit and slow down your taper. It's the same things that we always talked about with any of our drugs when we were tapering somebody off. If they start to experience symptoms, you put them back on and then you slow down, okay? Give their body time to wake up. What you can also consider in these situations is switch to a short-acting steroid. We're going to talk about that. You can also say, hey, I had this person taking it 2 times a day or 3 times a day, which we do have in some of our dose packs that are steroids. If we know that we're doing something like that, what you can try to say is, hey, let me see if they can tolerate taking this just in the morning. What benefit we get there is that that's usually when those levels are high anyway, naturally, right? So now when you try to take me off, it's not a huge shift, and my body's trying to figure out what's going on because that spike is still happening for them in the morning. So now it's easier for their body to adjust because their schedule is still almost the same, okay? You also can see alternative day dosing, not something that we prefer because remember, you don't give somebody something every day, they forget. So if you do the alternative day dosing, make sure you write the days that they're supposed to take it. And then making sure that you do this. I didn't underline this for a reason because we typically don't do it. We start tapering and then wait for our patient to tell us that something is wrong. Some providers do get a cortisol level before they completely stop or once they hit the end of their taper to see what that person's body is doing. Okay, so remember that the longer you provide or the higher dose that you provide that glucocorticoid, the body shuts off negative feedback. Your job is to then try to taper that patient, if you can, off of that medication, 5 to 20% every 1 to 2 weeks. As you're doing the taper, if there are flu-like symptoms, you increase that dose back up and then slow down your taper. You also have the ability to consolidate to make them just have a morning dose, or you can try to get a shorter acting or lower potency steroid if you can, okay? So focus on those underlying things. This is telling you when you're not likely to see any HPA axis suppression occur, right? So if you're giving them a dose and it's less than 3 weeks, alternative day dosing, which I told you we don't really use that much anymore, or that morning only dosing because it mimics naturally what's happening to cortisol, you're not likely to see HPA axis suppression in those situations. You are more likely to see it whenever you're looking at those doses that are over 20 milligrams. I'm not going to make you remember the equivalency chart of prednisone, but I will have it for you in the back when we get to the oral options that you have, because that's something that you can use later. When you're trying to switch people in between steroids, they're not all the same and they don't nicely line up for you. So you have to look at that equivalency chart to know, oh, if I'm switching from prednisone to methylprednisolone, what should my dosing be? There's a difference. So anything that's over 20 milligrams of prednisone equivalent for greater than 3 weeks, because remember we said anything that was over 2 weeks, we were kind of worried about HPA axis suppression. Anything that's over 1 month, so it doesn't matter the dose, now you've put me on it for a long period of time. If I'm taking greater than or equal to the 5 milligrams of prednisone, and I'm also doing that or taking something that's at bedtime, because that's not when I should see my spike, right? I should see that in the morning. So now my body is more likely to experience that HPA axis suppression. This is our gray window. Not going to ask you about this. Focus on the things that are in bold. Okay? These are, again, some of the topical things that you can see. The longer a period of time that they use it, the more likely they are to see this happening. And then that atrophy, we can use our retinoids for those. Now, here are conditions that we have that we use our topical steroids for. So low potency, what do you notice about these low potency things? Where are they, right? Face, they're occluded areas, whether it's naturally or you're putting a diaper, right, on. So these are low potency steroids. This should make sense for you. Your medium potency and your high potency, these are several different conditions, and most of the time this is where we typically will treat our patients. These are going to be more of your serious type skin infections. Usually the way that they appear, they're going to have a lot of weeping lesions, things like that's when you can see this. They're going to be super, super itchy. That's when you're using high potency, and it's not for a very, very long period of time. Okay? So these are your face or occluded areas. Body folds, this is like in our heavier set people or people who might have like big breasts, things like that, right? That's a natural body fold, okay? So that is a naturally occluded area now, right? So when you think about that, think about the occlusion, think about the face. Anytime you see that or you see a patient that's like that, low potency if what you're trying to treat is in that area, okay? Oh, look, the vehicles, they're back. We talked about them, right? So they determine how fast something is going to be absorbed, how long we're going to, how often we'll have to apply it. These are the same things that you already saw. Review again the things that are in bold, okay? So my thicker areas, I like my ointments with my creams. If something is exudative, right, I can dry. I have the drying effect with my creams, my lotions and gels. Those, I like those in my scalp and my hairy areas because they're not going to clump my hair together. They're not going to cause that folliculitis. They do sometimes, because of the alcohol content, they dry clearly, they dry quickly. Your foams, your mousses, and your shampoos, yes, they're good for your scalp and your hairy areas, but you got to take the pocket into account when we're looking at these, right? So more expensive, okay? All right. Money-making slide right here, big slide. This is the slide that gets a lot of people in trouble because it's hard to remember. And honestly, this is one of the ones that you just have to continue to review and remember. Because on those other lectures where you saw low potency or high potency and all those things that we talked about, this becomes a thing. Because I could just ask you and put triamcinolone, and you need to know that that is a low potency, okay? So this you do have to remember. When you're going through this and looking at low, medium, high, and very high, make sure that you're paying attention to the percentages because sometimes those percentages is what is causing the potency to change. What I mean by that is you have hydrocortisone, 0.5 to 2.5%. But whenever I look here and I see hydrocortisone valerate, right, there's a difference. So that's why I underlined this so you could see it. Now I'm in medium potency. When you see your triamcinolone, 0.025%, but once that percent hits 0.1, now I'm in medium potency. So pay attention to those as you go through this, okay? Some people think, well, how many questions could you ask from this and I'm going to throw it and I'm not even going to try to remember it. Don't do that. Because there could be several questions from this, right? Because there's several slides that just say low, medium, and high. So I'm fair warning, this is just a continuous review of you looking at these drugs. I tried to underline some of the things that I know kind of catches people up a little bit. There was something on here that I think I wanted to tell you don't worry about that I can't remember. Just make sure you go through here and you look at these and be very, very familiar with them because there are several questions that come from this in different forms, okay? Occlusion. We talked about occlusion. We don't want to occlude. Occlude increases potency up to 100%. Don't laugh. I was like, look at her. She's cute. She's very sweaty though, I'm sure. But occlusion, right? Understanding that the potency that I pick, if I have it occluded, now I could potentially make my low potency drug a medium or a high potency, right? So that makes a big difference if I cover something up. That's what I'm meaning. Make sure you pay attention to those skin folds, right? What's going on? What's naturally occluded? What did I have to put a diaper on? If that child wears a diaper, that's occlusion. So looking at these, I'm not gonna finish, y'all. I tried. Looking at these, y'all have class after this? Okay. I'll be back tomorrow for like 20 seconds. Very high potency, medium potency, and low potency. Some people will talk about these as classes. I'm not going to ask you that this way. When you do derm, they may ask you that, but I'm not asking you that. So you have very high, medium, and low. When you're looking at this, I want you to pay attention to what is bolded on these. Not, and I know it's like, well, girl, this whole slide. Okay, almost is the answer. So when you look at your very high potency, we have to taper off of this, right? Because I'm giving them something that is a high potency. their HPA axis is shut down because they have a high dose. It's the same things that we talked about with, like, if I gave them a high oral dose, right? Not exceeding that 2 to 4 weeks of continuous use. We talked about this in that derm lecture, where we can try to alternate it with some of our other meds to try to see, hey, can I help them steroid sparing? Can I alternate with some of these other drugs to get them what they need? Specifically here, you see your clobetasol. Most of your high potencies, I just want you to be aware of this. Most of your high potencies, you see that you can have up to 50 grams a week that they're taking before you're actually worried. With your clobetasol, you only have 2 grams. So this one is a lot stronger than what you're seeing with your other high potency. Avoid occlusive dressings. Caution if you have your fluocinolone, this might be one that you could potentially occlude if it was an area that they had to. So let's say you have a naturally occluded area and you needed to use a high potency because it's one of those chronic conditions. You could potentially use your fluocinolone in that situation. High potency, your occlusive dressings, use those with caution, but not your betamethasone. Okay? Your betamethasone is a no. Don't occlude it under any circumstance, but all these other ones with your high, you can potentially use them. Just make sure that your patient is watching out for those cushingoid symptoms that they could experience. Your medium potency, this is where we usually live. Most of our things that we treat, we have medium potency. If it is a large area, we prefer that, right? Because now I'm having to slather this all over my body. I'm going to likely have more systemic absorption. I don't want to use a high potency in that case because now more of that med is going to be going also all over my body and increasing the systemic absorption. So that's why you see us using our medium potency. I can also use it for a longer period of time. 3 months is where I'm capped at versus my 2 to 4 weeks. And then avoid the occlusive dressings again. Betamethasone is popping up, and now you see your fluticasone. And then your low potency, this is where we like to live for our elderly patients, our kiddos. Some of them are available over the counter because they are low potency. We do still try to make sure that if a patient does want it, you can prescribe it, that you don't have to tell them, well, just go and buy it. We have it behind the counter as well. Again, large areas as well are those occluded areas. We can use these. Preferred for the face, groin, armpits, or skin folds, which is what we kept hitting over and over and over again. Okay? Dang it. I'll start here tomorrow. All right? If y'all aren't doing anything at lunch and you want me to come during that time, you can also talk to the class leaders. Let me know what the thought process is. I don't know if y'all have something. Y'all have a review? Okay. Well, I will see y'all tomorrow at 1 for like 20 minutes. Okay?